what's left to discuss? Did you know that abnormal increase in blood glucose associated with the use of glucocorticoid in a patient with or without prior history of diabetes mellitus is going to induce steroid-induced diabetes mellitus in them? Well, the effect of glucocorticoid on glucose metabolism is likely the result of impairment of multiple pathways including beta cell dysfunctions. This beta cell dysfunction causes sensitivity to glucose and ability to release insulin, and the insulin resistance with other tissues. So, this SIDM or steroid-induced diabetes mellitus needs to be treated. And for that, we're going to use three kinds of approaches. Either giving insulin, because initiation of glucocorticoid can cause postprandial hyperglycemia, and the tapering of glucocorticoid can lead to normalization of glycemic control. Current guidelines suggest that insulin is a really good option. Oral secretagogues of insulin can also be given, such as sulfonylurea therapy, that do not specifically target postprandial hyperglycemia, and thus long-acting agents may be associated with hypoglycemia if the patient does not eat meals regularly. We can also give them incretin mimetics, and incretin-based therapy with GLP-1 receptors and DDP-4 inhibitors control glucose level by stimulating insulin and inhibiting glucagon secretion in the fast and postprandial setting. So this was just a bonus information that I would like to give you. Other than that, we have talked about corticosteroids and cortisol specifically, its release, its target cells, and the use of corticosteroids. So stick around for more to sqadia.com.
So Jimmy should not use steroids this much after all.
Hey, are you listening to the lecture tube?
Of course. You used a term anabolic steroid, so I got a little interested.
Well, I hope you got your concepts clear.
Sure, steroids have a love-hate relationship with our body.